Welcome to this Step 2 clinical knowledge review on inflammatory arthritis test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for inflammatory arthritis and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the rheumatology and musculoskeletal sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for inflammatory arthritis. Second, we will apply specific strategies for questions about rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. And third, we will master the disease-modifying anti-rheumatic drug therapy decision questions and the next best step format for inflammatory joint disease. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach. Our first strategy is the inflammatory versus non-inflammatory split. When you see a question about joint pain, immediately ask yourself, is this inflammatory or non-inflammatory? For inflammatory arthritis, the key features are morning stiffness lasting more than 60 minutes, symmetric small joint swelling, and improvement with activity. Positive rheumatoid factor and anti-cyclic citrullinated peptide antibodies point toward rheumatoid arthritis, while dactylitis and nail pitting point toward psoriatic arthritis. For non-inflammatory arthritis, look for brief morning stiffness under 30 minutes, asymmetric large joint involvement, and bony enlargement with pain that worsens with use. The boards absolutely love testing this distinction, so make this your first mental framework. Strategy 2 is all about distinguishing the spondyloarthropathies because the boards test these in so many different ways. For ankylosing spondylitis, look for a young male with chronic low back pain and morning stiffness that improves with exercise. The classic findings are sacroiliitis on imaging, limited spinal mobility, and positive human leukocyte antigen B27. The boards love presenting a young man whose back pain gets better with activity. For psoriatic arthritis, look for asymmetric oligoarthritis with dactylitis, nail changes like pitting and onycholysis, and skin plaques. Remember that psoriatic arthritis is seronegative, meaning rheumatoid factor is negative. Pencil cup deformity on X-ray is a classic radiographic finding. Look for the skin and nail findings to clinch the diagnosis. Now let us go through high-yield stem recognition. For rheumatoid arthritis, the classic stem is a middle-aged woman with symmetric swelling of the metacarpophalangeal and proximal interphalangeal joints, morning stiffness over 60 minutes, and positive anti-cyclic citrullinated peptide antibodies with elevated inflammatory markers. For ankylosing spondylitis, look for a young male with insidious onset low back pain and stiffness that is worse in the morning and better with exercise, plus bilateral sacroiliitis on imaging. The stem may mention uveitis or limited chest expansion. For psoriatic arthritis, the stem features asymmetric joint swelling with sausage-shaped digits, nail pitting, and scaly erythematous plaques. These stems repeat over and over on practice questions and on the real exam. Let us work through our first practice question. A 45-year-old woman presents with 6 months of bilateral hand pain and stiffness. She reports morning stiffness lasting about 90 minutes that improves throughout the day. On exam, there is symmetric swelling of the metacarpophalangeal and proximal interphalangeal joints, bilaterally. Labs show positive anti-cyclic citrullinated peptide antibodies and an elevated erythrocyte sedimentation rate. What is the most appropriate initial treatment? Take a moment to think about this before we walk through the answer on the next slide. Let us break this down step by step. Step 1, spot the pattern. Middle-aged woman, symmetric small joint swelling, prolonged morning stiffness, and positive anti-cyclic citrullinated peptide antibodies. This is classic rheumatoid arthritis. The symmetry and antibody results are the key differentiators. Step 2, apply the rule. The board rule you must memorize is: methotrexate is the first-line disease-modifying anti-rheumatic drug for rheumatoid arthritis. Early initiation prevents joint destruction. Do not rely on anti-inflammatories alone for disease control. Step 3. Eliminate wrong answers. Ibuprofen alone provides symptom relief but does not prevent joint damage. Prednisone taper may bridge symptoms but is not first-line long-term therapy. Adalimumab is a biologic agent reserved for patients who fail methotrexate. The The correct answer is B, methotrexate. Here is our second practice question. A 26-year-old man presents with a 3-year history of low back pain and stiffness that is worst in the morning and improves with physical activity. He also reports a recent episode of eye redness and pain. On exam, there is limited lumbar flexion and tenderness over the sacroiliac joints. What is the most appropriate next step in diagnosis? Think through this one carefully. The key features here are young male with inflammatory back pain and uveitis. We will walk through the answer next. Let us work through this answer. First, read the question carefully. This describes classic ankylosing spondylitis. Young male, chronic low back pain that improves with exercise, morning stiffness, uveitis, and sacroiliac tenderness. Rheumatoid factor testing would be wrong because spondyloarthropathies are typically seronegative. Serum uric acid is for gout, which presents very differently with acute monoarticular pain. Arthrocentesis is not performed on the spine. Now, why does sacroiliac imaging win? Because X-ray of the sacroiliac joints is the first-line imaging study and will show sacroiliitis, which is the hallmark finding of ankylosing spondylitis. If X-ray is inconclusive, magnetic resonance imaging of the sacroiliac joints is the next step. The correct answer is B, X-ray of the sacroiliac joints. Let us review disease-modifying therapy for the boards because this comes up constantly. Methotrexate is the first-line disease-modifying anti-rheumatic drug for rheumatoid arthritis and psoriatic arthritis with peripheral joint involvement. You must monitor liver function and complete blood count regularly. Folic acid supplementation is given to reduce side effects, and this drug is absolutely contraindicated in pregnancy. For escalation therapy, tumor necrosis factor inhibitors such as adalimumab and etanercept are used when methotrexate fails or is contraindicated. For ankylosing spondylitis specifically, nonsteroidal anti-inflammatory drugs are first line, with tumor necrosis factor inhibitors for refractory disease. One more high-yield pearl. The boards love asking about screening for tuberculosis before starting biologic therapy, because these drugs suppress the immune system and can reactivate latent tuberculosis. Here is our third practice question. A 35-year-old man presents with swelling of the right knee and left third toe that appears sausage-shaped. He has a history of scaly plaques on his elbows and scalp. On exam, there is pitting of several fingernails. Rheumatoid factor is negative. What is the most likely diagnosis? This is a classic pattern recognition question. Think about all the physical exam clues and what diagnosis ties them together. We will walk through it next. Let us break down this answer. The classic pattern here is asymmetric oligoarthritis plus dactylitis plus nail pitting plus skin plaques plus negative rheumatoid factor. This combination is textbook psoriatic arthritis. Dactylitis, or sausage digit, is one of the most specific clues on the boards. Now the key distinction. Rheumatoid arthritis is symmetric and seropositive, which does not match this presentation. Reactive arthritis involves urethritis, conjunctivitis, and arthritis following an infection, which is not described here. Gout presents with acute monoarticular pain and negatively birefringent crystals, not dactylitis with skin plaques. The correct answer is B, psoriatic arthritis. Here is a critical test-taking pearl about lab and imaging patterns. Anti-cyclic citrullonated peptide antibodies are highly specific for rheumatoid arthritis, while rheumatoid factor is sensitive but not specific and can be elevated in other conditions like hepatitis C and Sjogren syndrome. Human leukocyte antigen B27 is associated with ankylosing spondylitis but is not diagnostic on its own. Elevated inflammatory markers support the diagnosis but are never definitive. For imaging, rheumatoid arthritis shows periarticular erosions and joint space narrowing. Ankylosing spondylitis shows sacroiliitis and bamboo spine. Psoriatic arthritis shows pencil cup deformity and periostitis. Here is the important point. The exam loves asking you to match the imaging pattern to the diagnosis, so commit these associations to memory. That wraps up our review of inflammatory arthritis test-taking strategies for Step 2 clinical knowledge. Remember to review the rheumatology and musculoskeletal chapters in First Aid and your question bank. Focus on the diagnosis, disease-modifying anti-rheumatic drug therapy, and imaging findings we covered today. Visit www.roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.